Good afternoon. Welcome to our academic session today. And today it's our pleasure and privilege to introduce Dr. Asha, Professor and Head of Endocrinology. Very thankful to ma'am for having taken the time off to take us through a session which we have been longing to know about, in fact, from the whole department. And my special thanks to Dr. Tambu sir for having suggested the topic and also for having coordinated this event as well. And once again, thank you so much, ma'am, for having come. And we look forward to knowing more about CGM so that we can probably make use of this facility more towards better care of our patients. We look forward to the session. We'll hand over to you without any further delay, ma'am. Thank you.
Thank you. Thank you, sir, and thank you, Vignesh. Should I join? Okay. I thought we would briefly discuss about the utility of continuous glucose monitoring in our day-to-day management of patients with diabetes. So I will just give a brief overview of what the technology is and mostly concentrate on the clinical utility of this measurement for our clinical practice. So we all know that glucose measurements are critical to effective diabetes management. And we are aware that recently, in addition to the long-term glycemic control, glycemic variability has been brought in as a parameter that influences the complications, long-term microvascular and macrovascular complications of diabetes. So the parameters which we commonly use are HbA1c and self-monitored blood glucose levels. So let's look at their utility for us. HbA1c will give us the average glucose values over the previous 2 to 3 months. It's a validated indicator of the risk of complications. Various studies have shown undoubtedly that HbA1c correlates with the complications, but it does not reflect the rapid changes in blood glucose values, which happen on an everyday basis. Again, it's also unreliable in patients with anemia, hemoglobinopathies, those with iron deficiency, B12 deficiency, as well as during pregnancy when there is a physiological hemodilution. So in such situations, it becomes unreliable. So we need other parameters. So what we do right now is to depend on self-monitored blood glucose levels in such situations where we can't depend on HbA1c alone. So here we need to do a finger prick test, but it gives only a point of care, one point in time measurement of blood glucose value. It does not indicate the direction of the glucose fluctuations. It is also dependent on the patient's willingness to check and fails to detect nocturnal and asymptomatic hypoglycemia. So while there are some advantages of self-monitored blood glucose, which we do depend upon when we can't rely on HbA1c, again, it's not useful for all aspects. So continuous glucose monitoring helps us to track the glucose concentrations in the interstitial fluid and addresses many of the limitations we have with regard to HbA1c and self-monitored blood glucose. So this technology is the result of the work by Professor Leland Clark, who introduced these electrodes as early as 1956, and later on used this principle of electrochemical sensors in the technology of glucose measurement. So these sensors, they have a glucose oxidase sensor. When glucose is oxidized to gluconolactone, the electron that is generated has to be taken up by oxygen. This in turn will excite an electrode and is measured as an electrical signal. That's how the principle works. Of late, we also have other sensors which we use glucose dehydrogenase and other electron acceptors as well. Various types of sensors are available which are utilized in glucose monitoring technology for the glucometers. We have the glucose oxidase systems and the glucose dehydrogenase systems and glucose dehydrogenase pyrroloquinone, that is GDH-PQQ systems as well. So it is the same type of sensor for the glucometers as well as the CGM devices. We also have a different technology now that is known as fluorescence-based implantable CGMs, which contains an implantable detector. The detector is inserted into the subcutaneous tissue that senses glucose based on a polymer that is coated on the sensor, and that in turn excites the fluorophores, and the excitement is detected as a fluorescent signal measurement. The advantage of this technology is that it can be implanted into the subcutaneous tissue and can be retained there now even up to 1 year. It's available in the US, not yet available in India. But the problem is that this has to be surgically implanted under the skin, but it runs for 1 year. It is compatible with various imaging techniques as well. So in that way, it is a stable, robust sensor. So that has a transmitter, which is worn on the skin, that is detachable, and that in turn transmits signals through Bluetooth to a mobile application that can give us the readings. That's about the technology. Now, what is the data we get when we get the continuous glucose monitoring results? So this is how the graph looks like. This is a wider picture of small ranges of the graph. So what do we actually measure on a continuous glucose monitor? We are interested in what proportion of the time in a day the glucose levels are in range. That is time in range. That is glucose levels ranging between 70 to 180 milligram per deciliter. And what is acceptable is at least 70% of the total 24 hours should be time in range. We are also concerned about time below range, which is the hypoglycemic range. It should be between 70 to 54 should be less than 4%, and below 54, that is level 2 hypoglycemia, should be less than 1% of a total day. 1% is about 15 minutes. That is roughly the calculation. Time above range should be less than 25%, between 181 to 250, and time in the very high range more than 250 should be less than 5%. These are the main aspects which we would be concentrating on when we clinically use these devices. But there are also other parameters which would help us fine-tune our glucose management. So that is standard deviation, which is a measure of variation of all the glucose measurements. Mean amplitude of glucose excursions, that is the magnitude of glucose excursion which exceeds one standard deviation, that is the mean amplitude of glucose excursions. CV is standard deviation divided by the mean glucose. A CV less than 36% is what is recommended for a less variable glucose control. We also have other measurements like conga. Let's not worry about that. That is again a combined measurement of the magnitude and amplitude of excursions. And we also get a value known as estimated HbA1c or glucose management indicator, which is an estimate of the HbA1c derived from the average of all the CGM readings over a 14-day period. So this is a sample report of a FGMS of a patient. So what we can see here is that the target range for this patient is 47%, while ideal would be 70%. The high between 181 to 250 is 23%, that is acceptable, but very high 20% is not acceptable. It should be less than 5%. Again, the low values 70 to 54, 4% acceptable, but very low is 6%, while we would like to have it less than 1%. We do not want to have so many severe, not severe, but so many level 2 hypoglycemias. This is the average of the 14 days, and it generates a graph like this where we can make out which are the time periods where the patient is having hypo or hyperglycemic excursions. So here we can make out that the glucose level starts rising after 6 a.m. and until about 11 a.m. It is high. Similarly, in the evening it starts rising and again goes up. So we need to concentrate on the basal dose of insulin, which is there in the early morning. And also we need to concentrate on the insulin dose for the snacks and the dinner. In addition, we also get daily graphs like this where we can make out at what points in time during a day the glucose levels are going up. Bigger versions are also available. Just to put everything on one slide, it's like this. So what is this glucose management indicator? This is an estimated HbA1c. Which is an integrated measurement of all the glucose values, which is converted into an estimated average glucose. So when people looked at the actual HbA1c of the patients and what this glucose management indicator gives as a HbA1c, there was significant variability in about 25 to 30% of patients. So this is not a very reliable measurement of the average glucose, the glucose management indicator, but it may help us understand the direction in which we are going. So whenever we look at any technology to assess glucose measurements, we are concerned both about the accuracy as well as the precision. So when the same measurement is done multiple times, how likely are we to get the same reading or a similar reading? So accuracy refers to how close the test results are to our reference standard, while precision refers to the consistency of the measurements. So when these devices are calibrated, they were actually calibrated based on the accuracy of the CGM sensor read glucose values in comparison to capillary or venous blood glucose levels. So this concordance also depends on the difference between the two compartments, because in one compartment, in the CGM, we are measuring interstitial glucose, while blood glucose is a direct measurement of the blood glucose levels. So normally there is a lag time of 5 to 10 minutes between for the glucose to transmit from the capillary to the interstitial fluid. So that much of delay is an expected delay. So there is a measurement which is known as mean absolute relative difference, which is the mean difference between the sensor readings compared to a series of simultaneous blood glucose reference samples. So lower the MARD, lower the relative difference, more accurate the device is. So CGM accuracy is defined by the MARD, and that is the current standard to assess the accuracy of a CGM device, and a MARD less than 10% is considered as appropriate. So what is the MARD of our SMBG, the glucometers? It again ranges from 4.4 to 13%. So in addition, because CGM gives us a lot of readings, these readings are plotted on a graph against the blood glucose readings, capillary glucose readings, and a graph is plotted like this. So all the values that are in the Clark error grid analysis, A and B, they are considered as relatively accurate, and that leads us to the right direction of treatment. So Clark's zone A is clinically accurate with values within 20% of the reference sample. Zone B is around 20%, but will not lead to inappropriate treatment. So values within this zone are acceptable, while zone C would lead to either overcorrection or undercorrection of glucose values, and zone D is dangerous failure to detect the correct value. So these were done with the Freestyle Libre sensor with the same glucose measuring device. So there are also standards laid down for the accuracy of the CGM measurements as well as the blood glucose measurements with glucometer. So the FDA requirement is that overall more than 87% of the values should be within 20% of the measured value. And the ISO requirement is that more than 95% of the values should be within 15 milligram per deciliter for values below 100, and within 15% of difference with the blood glucose measurement. So there are certain CGM sensors where you have to do finger prick measurements intermittently in order to calibrate the CGM. Previously, we had the Medtronic CGM devices where we had to calibrate it every 12 hourly. Some even needed calibration every 6 hourly. Also, in the first 24 hours after the sensor is applied, there may be more differences between the measured glucose in the capillary versus the CGM. It usually attains to a stable state after 24 hours of insertion. So we need to be careful in interpreting the first 24 hours and also confirm it with self-monitored blood glucose values. Also, when the patient has hypoglycemic symptoms, but your CGM is not yet showing it, because there is a sensor lag time of 10 minutes. So the patient may be hypoglycemic, but the sensor is still showing 80, 85. So if you measure after 10 minutes, it may be going below 70. So in such situations also, you need to do finger prick glucose values. And when the symptoms do not match to the glucose level detected, also you have to check with finger prick glucose. In certain countries, the regulations still require that they do finger prick glucose measurements before driving, and such regulations would have to be followed. So looking at how these different devices work, Dexcom devices are available in US. We have Guardian 3 and Guardian 4 sensors that are available in India, and we also have Freestyle Libre 2. These three are available in India. The others are not yet available in India. So these devices, the Dexcom devices and the Guardian devices, measure the glucose levels every 5 minutes. And these readings are stored in the sensor, and when you read them, you will get it as a graph as well as the actual glucose values. The Freestyle Libre is a intermittently scanned CGM. So when you scan, you get the preceding results. Whereas with regard to Guardian 2 and 3, the readings continuously keep coming on your mobile, irrespective of the scanning. So with Freestyle, we get the readings every 1 minute. And similar with Freestyle Libre 3, which is available in Europe, not yet available. Recently, some devices have come to India. Eversense also measures every 5 minutes. And the sensor duration is about 10 days for Dexcom devices, 7 days for Guardian, 14 days for Freestyle, which we are using here. Calibrations are optional for Dexcom, every 12-hourly calibration required for Guardian, and no calibration is required for Freestyle because it is a factory calibrated device, doesn't require calibration. And all the real-time CGMs, which are constantly measuring and transmitting, they give alarms as well. And so we have low glucose alarms, which are available for Dexcom and Guardian, and they give a beep when the glucose levels are going below 70. These two devices also integrate with insulin pumps, and they're used in automated insulin delivery devices, so that the CGM will talk to the pump and adjust the rate of insulin delivery by the pump. Those are the automated insulin pumps. The 670G insulin pump hybrid closed loop is available in India, and we are using in a few patients with type 1 diabetes, and that helps them maintain a relatively good glycemic control, because the pump can automatically give by itself give extra doses of boluses whenever the glucose levels are going up. It can suspend when the glucose levels are coming down. So in that way, the pump will talk to the sensor and adjust the glucose values. Freestyle Libre 2 Plus has a system where it can alert on the phone when the glucose is falling down, but Libre 2, which we are using currently, doesn't have that alerts. It can be inserted on the abdomen or on the back of the arms. The Freestyle, which we are using, is usually inserted on the back of the arms. The warm-up time is about 1 hour. So once you insert the sensor, it takes about 1 hour for it to start working. Freestyle Libre devices are approved for use above the age of 4 years, and it is read with a either with the reader or with a mobile app, that is the Libre Link, Care Link, etc. Different apps for the different devices. So what are certain problems which we encounter? Because these sensors are stuck to the skin, and the catheter goes into the subcutaneous tissue. Some people may be allergic to the adhesive that is used, so can cause contact dermatitis. And some of the skin sensitizers that are used before applying the sensors can cause allergic reactions. Certain medications which are commonly used, especially acetaminophen, ascorbic acid, can cause falsely high sensor readings, especially vitamin C. You should ask the patients whether they are on vitamin C while using the Freestyle Libre sensors. Hydroxyurea can cause falsely high values with the Dexcom and Medtronic sensors. mannitol and sorbitol with the Eversense sensors, that is the implanted sensor, which we are not using here. So the international consensus recommends that when you are interpreting CGM data and utilizing it for making treatment decisions, it should be used for a minimum period of 2 weeks, and at least 70 to 80% of the readings are retrievable. In the Freestyle Libre 2, which we are currently using, if the device is not scanned for 8 hours, whatever is before that, the data will be lost. So it should be scanned at least once in 8 hours, otherwise the intervening data will be lost. So at least you should have 70 to 80% of the data that is available. Glycemic variability should be less than 36% as measured by the CV, and standard deviation should be as low as possible. The glycemic management indicator should be provided by the device, and the episodes of hypoglycemia or hyperglycemia are defined as episodes lasting at least 15 minutes. We can also get the area under the curve, low blood glucose index, as well as the high blood glucose index. So what are the clinical targets? As discussed earlier, we should have at least 70% of the data. Longer periods of wear will give you more data. And the primary goal is to improve the time in range while reducing the time below range. And it was seen that an increase in the time in range by about 10%, that is 2.4 hours per day, corresponds to a decrease in HbA1c by 0.5% in type 1 diabetes and 0.8% in type 2 diabetes. So again, the international consensus for time in range is at least 70% for all type 1 and type 2 diabetes, and for older individuals, high risk individuals with multiple comorbidities, about 50%. And for all the low blood glucose, that is the time below range, less than 4%, less than 1% below 54. And for high risk individuals, the time below range should be ideally less than 1%. So with regard to managing diabetes in pregnancy, because we need to have tighter glycemic control in pregnancy, we have lower targets, that is 63 to 140 rather than 70 to 180 for our routine type 1 and type 2 patients. So here it is 63 to 140 in pregnancy complicating type 1, type 2 diabetes or gestational diabetes. And here for type 1 diabetes, the time in range should be at least 70%, but for type 2 and gestational diabetes, at least 90% of the values should be within target range. Less than 5% hypoglycemia as well as hyperglycemic excursions are preferable for GDM or type 2 diabetes complicating pregnancy. So this glycemic risk indicator was derived from CGM data of 1,067 children and adolescents, and it was derived using various CGM devices, and comparing the hypo versus the hyperglycemic risks. And it was shown that the glycemic risk indicator was lowest with the hybrid closed loop as compared to the multiple daily injections. So somebody uses a CGM along with a pump, then their glycemic risk is lowest. So various meta-analysis have shown that have assessed the changes in HbA1c, time in range, time below range, time above range, and in the largest meta-analysis, which included about 2,400 patients, assessing change in HbA1c and time in range with the use of real-time CGMs or intermittently scanned CGM like the flash devices, that is the Freestyle Libre, which we use. In the mean age group ranging from 11 to 67 years, it was found that the HbA1c was 0.17% lower with the CGM than with controls. And there was a significant increase in time in range while using CGM devices. The increase in time in range again was significant and robust with the use of CGM devices, irrespective of the type of diabetes or the method of insulin delivery. So one important use of CGM is to detect hypoglycemia unawareness, which is a significant problem among patients on long-term insulin, especially those with type 1 diabetes, where they have very highly fluctuating glucose levels. So we have two studies that have looked at that, that is the HypoD and in control studies. So the HypoD randomized control trial reported a reduction in the duration of hypoglycemia to 24 minutes per day in the CGM group versus 92 minutes per day in the control group. And in the in control study, again, there was a decrease in the mean time in hypoglycemia by about 1.1 hour with the use of CGM. Though there was no significant change in the HbA1c reported in both the studies, and hence continuous glucose monitoring is useful in managing patients with hypoglycemia unawareness. First of all, to detect hypoglycemia unawareness, take corrective action and reduce further hypoglycemia. So this was a trial in routine clinical practice in the UK, where they looked at the efficacy of intermittently scanned freestyle Libre sensors and its effect on HbA1c in patients with type 1 diabetes. So the mean age was about 44 years, and in this study, it was found that at 24 weeks, that is with 6 months use of CGM, HbA1c decreased by about 0.7% in the CGM group compared to only 0.2% reduction with a comparator group, that is self-monitored blood glucose levels, with a difference of 0.5% better control of HbA1c with the use of the flash glucose monitoring system. So this is how a freestyle Libre record looks like. As I showed you earlier, it gives a median line of the glucose values, and also it indicates the patterns of the timing of changes. So here we see this patient's glucose levels are starting to increase by 7 a.m. and continue to be elevated up to 11 a.m. and again starting to increase in the evening. These are the daily graphs where you can see what has happened on different days. Obviously, this is a patient with type 1 diabetes who has highly fluctuating blood glucose values. We also get daily readings like this. So based on that, you can change the insulin doses, the activity, the food patterns, and try to get in better glycemic control. So we have seen here that the fasting glucose levels were high. So basal insulin would have been increased, and so that has led to some hypos here. This is a patient with type 2 diabetes, where you can see the curve is relatively smooth, only one peak around lunchtime. And so that was well controlled with oral medications itself. Here you can see the estimated HbA1c was 6.1%, indicating that this patient has a smooth profile of glucose values. So there are various studies that have looked at the utility of CGM on glycemic control in type 2 diabetes, 12 RCTs, 1,200 participants. CGM led to a reduction in HbA1c by about 0.3%, and the effect was comparable among insulin users as well as OAD users. So CGM was associated with an increase in time in range by about 6%, decrease in time below range, as well as decrease in glycemic variability even in type 2 diabetes. So next, looking at its integration with insulin pump, we have two types of pumps where the pump functions by itself, which is regulated by the patient and the physician. And we have hybrid closed loop systems where the pump will talk to the CGM and adjust the rate of insulin delivery. Sensor augmented pump is somewhere in between, where it has low glucose suspend values. So the hybrid closed loop algorithms automatically increase, decrease, or suspend insulin delivery to maintain a glucose level of about 120. So what is available in our country is the Medtronic CGM system 670, which is a automated insulin delivery closed loop system that is available in India. So in a multi-center randomized control trial in patients with type 1 diabetes who were assigned to closed loop system versus the sensor augmented pump, it was found that the closed loop system led to the primary outcome, that is the better time in range of 61% versus 59%. And also the glycemic benefits associated with closed loop were seen as early as the first month of its use, though there was no significant change in the insulin doses between the two groups. This was another study, which was a crossover study between sensor augmented pump and closed loop, and again found that time in range was better with the closed loop as compared to the sensor augmented pumps. Also, the number of severe hypoglycemias were reduced and decays were avoided by using sensor augmented pumps. So closed loop therapy was found to be an effective treatment option, even for older adults with type 1 diabetes, no safety issues, higher time in range, less time below range, and less time spent in nocturnal hypoglycemia. So when it comes to exercise for type 1 diabetes, again, that is a challenge, because when they exercise, the glucose levels can go down, and that hypoglycemia can occur as a delayed effect as well. They can have delayed hypoglycemia even up to 12 hours after an exercise. So in order to avoid this, we often tell them to take extra carbohydrates or give them lesser doses of insulin prior to the exercise. So this is the current recommendation by the ADA, that we have to, depending on the intensity of exercise, we have to reduce the insulin doses proportionately. When we use a CGM, it's often easy to detect these glucose fluctuations, and we can set the insulin pump settings to a lower level at a temporary basal level to reduce these exercise-induced hypoglycemia. Now coming to pregnancy, we're all aware that pregnancy with type 1 diabetes again is associated with increased glucose variability. They can have hypoglycemia in the first trimester, hyperglycemia in the second and third trimester, as well as impaired hypoglycemia unawareness. And also there is an increased risk of pregnancy complications in these patients, especially miscarriage, preeclampsia, congenital anomalies, large for gestational age, and NICU admissions. So can we use a CGM in order to be able to fine-tune the glycemic control in patients who are going through pregnancy? This was studied in the concept study to evaluate CGM use in pregnant women with type 1 diabetes. So they enrolled patients in 31 centers from different countries, mainly Europe and USA, pregnant women. They were in two arms, those who were planning pregnancy and those who were in the first trimester of pregnancy, equally randomized to CGM or self-monitored blood glucose or self-monitored blood glucose alone. And so the primary outcome was change in HbA1c from baseline to the pre-specified endpoint, that is at 34 weeks of gestation, in pregnancy or at conception. For those who are planning pregnancy, the CGM metrics were also studied in these patients. So it was found that among type 1 diabetes women who were randomized to use CGM, there was a mean difference in HbA1c of about 0.2%. There was a better time in range as compared to self-monitored blood glucose, reduced hyperglycemia as well as hypoglycemic excursions. Also, the proportion of infants who were large for gestational age, the risk of neonatal hypoglycemia and NICU admissions were also reduced with the use of CGM. So technology was useful to achieve better obstetric outcomes for these pregnant women who had diabetes in pregnancy. The number needed to treat with CGM to prevent one complication was 6 patients to prevent NICU admissions and large for gestational age, and 8 patients to treat neonatal hypoglycemia. This is quite impressive. So next, coming to the comparison between the real-time and intermittently scanned CGM devices, that is the freestyle versus the other real-time CGM devices. So in this study, in a cohort of 186 pregnant women, where they compared real-time versus intermittently scanned CGM, there was no significant difference in the maternal and neonatal outcomes between the two devices. What about the use of CGM in elderly? So in a randomized control trial, which included 131 older adults above the age of 65 years with type 1 diabetes with episodes of hypoglycemia who were on CGM for 6 months, the intervention group had less hypoglycemia and had better glycemic control as compared to those who used self-monitored blood glucose levels. So this is just an example of what we did last year. So this was a 81-year-old, one of our retired staff who has long-standing type 2 diabetes, multiple comorbidities related to diabetes. And he, because of his mobility issues, he was unable to come to hospital. His HbA1c was 8%, his creatinine was going up, and he was on nearly 120 units of insulin per day. Despite that, his sugars were not controlled, and he had problems related to that. So we requested one of our diabetes educators to put on a CGM, HGMS for him at home. When she went, she also found lipohypertrophy at the injection sites. We advised him to change his injection sites and change the needles every day. And after this, we found that he had significant hypos. So we had to actually come down on the insulin dose by nearly 30 to 40 units. And now he is well controlled. Once in 1 or 2 months, he wears the flash glucose monitor for 2 weeks. And the family is able to help him adjust the insulin levels and avoid hypoglycemias. So in that way, it is useful for remote care as well. This is a patient whom we have been managing for the last 1 year on remote care. So the Endocrine Society guidelines recommend that patients who are using CGM should continue to use CGM even when they are admitted to hospital. But we need to be aware of the interference due to medications, especially ascorbic acid, paracetamol. And for radiological studies, CGM can be worn during chest X-rays and CT scans, but for MRI procedures, we are not sure about its safety, and so it has to be removed. There was one study which looked at the use of Dexcom sensors during a coronary artery bypass surgery and found that it was able to detect most of the times except during electrocautery or diathermy procedures where the signal was lost. Again, its use is limited in patients who are on the hyperbaric chamber because the glucose oxidase system gets affected by this. CGM has also been studied in relation to its effects on diabetes complications. This was a study in 20,000 participants, including 22 studies on type 2 diabetes and 9 studies on type 1 diabetes and 3 with mixed populations to assess the effect of glucose variability on the diabetes complications. So it was found that microalbuminuria was significantly associated with the standard deviation, the CV and the MAGE. EGFR was significantly associated with the standard deviation and albuminuria with the time above range. Also, retinopathy was significantly associated with glycemic variability metrics. It was associated with all the severities of retinopathy, including preclinical neuroretinal abnormalities. And every 10% increase in time in range reduced the risk of retinopathy by 64%. This is much more than the change shown by HbA1c in the earlier DCCP studies. Again, neuropathy was also associated with glycemic variability, especially with lower time in range and the mean amplitude of glucose excursions. Cardiac autonomic neuropathy was only associated with time in range. While chronic sustained hyperglycemia causes protein glycation and thereby causes the complications, the acute glucose fluctuations causes oxidative stress, thereby increasing inflammation, endothelial dysfunction, and altered gene expression, thereby affecting the long-term complications of diabetes. So various studies have shown that the effect of glycemic variability on the complications persists even after you adjust for HbA1c. So the current guidelines recommend that CGM devices should be offered for diabetes management for all patients who are capable of using the devices safely, especially adults on multiple daily injections, type 2 diabetes or type 1 diabetes on multiple daily injections or continuous subcutaneous insulin infusions. And the choice of device again depends on the circumstances, the availability, and for those using pumps, the compatibility with the pump. CGM is also recommended in pregnancies associated with type 1 diabetes specifically, and also in type 2 diabetes where you have difficult to control diabetes. And real-time CGM has been shown to reduce the risk of neonatal complications. The NICE guidelines also recommend using CGM both for type 1 and type 2 diabetes. So just to end with a few practical points, it is important that patients using CGM should be educated and explained about the utility of the technology. In Indian summers with increased humidity and sweating, the sensor may fall off. So we have to use a Tegaderm or some other form of stickers to avoid dislodgement. Glycemic variability among patients on insulin, especially type 1 diabetes, will also depend on what food they have taken, what activity they have done during those days. Hence, we also tell them to keep a log of these things while using the CGM so that they'll be able to better understand the effect of various foodstuffs, the different types of activity on their glucose variability. And in addition, we need to have a strong team of diabetes educators and dietitians who are also able to understand these curves and advise the patients on a regular basis while they're using this technology. So to summarize, CGM is a useful tool to understand the dynamics of glucose fluctuations and take measures to control. Very useful for type 1 diabetes with highly fluctuating blood glucose levels, those with hypoglycemia unawareness, pregnancy, for remote care of elderly, and those involved in very active sports. Glycemic variability, as we have understood, has an important role in the long-term complications of diabetes, and it can be used even in hospitalized patients, keeping in mind the effect of drugs and use of oxygen therapy.
Thank you so much, ma'am. In fact, it was a great learning for me personally as well. Hopefully, it would have been the same for all the others as well. Any questions?
This is some different kind of question. Yes. Many of our patients in medicine OPD, obese, pre-diabetics, and then they don't follow diet or exercise. I was just thinking when you are talking, can we use this to help those kind of people? Because your guidelines finally ended with saying only type 2 on insulin, but these are pre-diabetic or maybe just pre-diabetic on metformin. Can we use it for those kind of patients?
Yes, sir. Surely we can use, especially they will understand what kind of foods can increase their blood glucose levels. And they will also see the effect of exercise and diet control on their glucose levels. So that will be motivating for them as well. Quite a few of our patients with type 2 or pre-diabetes do request to use this to understand these patterns.
In all your studies, like most of the ones in India is only for 14 days. So how often are they just continuously on the CGM or every month? Like how do you actually do it?
Yeah. See, what is ideally recommended is to use it continuously, especially for patients who are on insulin, especially for type 1 diabetes and during pregnancy. But for the others, it can be used intermittently, say 14-day slot in a month or once in 2 months, so that they understand the fluctuations, and then the remaining days they can do self-monitored blood glucose. Or for a short period, like sir said, for them to understand what increases the glucose levels, what are useful to keep it under control.
And what about the costs for all these devices?
Yeah. So the cost of the current sensor which we are having, that is the Freestyle Libre 2, is 5,000 rupees for the sensor. Nowadays, readers are not required. Reader also costs 5,000 rupees. It can be used any number of times. Only the sensor will have to be replaced every 14 days. But nowadays, most of the mobile applications are able to read it. So you don't need a reader, you only need a sensor. There are now various other competitive brands that are coming up, which are giving sensors for 3,500, 4,000 rupees. But almost all are around that figure.
Time in range is probably replacing HbA1c as the gold standard.
Yes. Yes. That is what. Closed loop means it is tagged to a pump.
Yes.
So where the pump and the sensor will coordinate with, yes, it's being used. So in fact, we've had very good results with the closed loop, hybrid closed loop systems. Few of our patients who found it very difficult to manage their diabetes for a long period of time are now getting to HbA1c of 6.5 to 7% with the use of hybrid closed loop pumps. Some people who remained at 8 and above always.
And the
Type 1.
costs for
Cost is huge. The pump cost itself is about 6 to 6.5 lakh rupees as the beginning investment, and running cost is 20,000 rupees. The running cost is the main thing per month, because the Guardian sensor runs only for 7 days. So they need 4 sensors per month. That itself costs about 10,000 rupees. It is 2,500, but only 7 days. So 4 sensors, 10,000 plus insulin plus tubings. The tubings have to be changed every 3rd day. Yes.
Suppose we want to order an this is only for CMC people or the online people. So is there a system where we order CGM where the nurse will order the CGM, Tegaderm, put it and explain everything? Or we have to order the Tegaderm and the CGM device and then send them to diabetic? How does it work in outpatients?
Sir, for the diabetes educator, we have a CGM tariff also. So the tariff itself reads as continuous glucose monitoring. That is the charges for the nurse to do all the procedures, but the Tegaderm and the device have to be ordered separately.
So if we are sending somebody to diabetic educator, we should order the Tegaderm and the CGM device and the CGM charge.
Yes. So that nurse will follow up the patient for the 14 days and help them adjust their insulin dose. Also take their readings periodically and explain.
How do the patient correspond with the diabetic?
So once they go, they are given a form. They are told every alternate days to meet the diabetes educator.
Can they do it electronically or
they can do it? For patients who are going home, they can do it.
They can do that. Wow.
Any other questions? Any questions from the online participants? If not, again, thank you very much, ma'am. One more round of applause to ma'am, please. It was once again a great learning for us, and we look forward to continuous learning from your and your department as well. Thank you, sir, as well.
Thank you. Thank you, sir. Thank you all.
Thank you all.
Thank you all.
You have some refreshments you can have on your way.